Hey everybody, thank you for being here today. Um, I'm Eric Stein with Families Fighting Flu. I'm the Marketing, Communications, and Program Specialist at Families Fighting Flu. And today we have an excellent panel with you guys, for you guys that we've put together with help from Ruth from the Extension Foundation. Um, and we're really excited to have everybody here watching. This is going to be a panel with experts on tribal health and public health within tribal communities and people of tribal descent. And we're really excited to have everybody here. First, I'd like to start out by having everybody introduce themselves, talk a little bit about what makes them an expert in this field, why they're so passionate about it, and why they're on the panel today. So first, I'd like to start with Sonia, please.
Yes, hi, thank you, Eric. Doja Maragoa Uihishimish Head Mabizigits. My name is Sonia Abe. I am an enrolled member of the Mandan Hidatsa Rikra Nation on Fort Berthold in North Dakota. I'm here on the panel today. I feel I'm subject matter expert for many reasons. Lived experience as an Indigenous person and also working in public health for over 20 years. I've worked with our tribal health and Department of Health as well. I've worked in large private sector with facilities and then also local public health. My lived experience in 2000, I was diagnosed with meningitis, and that was a long adventure. I relapsed 3 times and finally was in a medicated coma for about a week and a half. And so I'm here, and yeah, all is well. So I'm glad to be a part of the panel and share my input. Thank you.
Wow. Thank you for sharing that story, Sonia. Um, Next, we're going to have Dr. Scott introduce herself.
Yeah, Eshe Ela Kodaskat Inisha Eshi Hinisha Twitchin Ibashichin Litslana Edashche Dodashnele. Hello everybody, my name is Lakota Scott. I am a naturopathic doctor and I work as the Tech IVAC, which is our adult vaccine promotion program with the Northwest Area Indian Health Board. And then I also manage the Native Boost program, which is our childhood vaccine education program.
Awesome. Thank you. Dr. Weiser.
Hello, everybody. I'm Tom Weiser. I'm a family physician and epidemiologist, recently retired from Indian Health Service, where I served most of my 25 years as a commissioned officer. I have worked a lot on immunizations with the Northwest Portland Area Indian Health Board and with Indian Health Service. And as far as my own personal story with immunizations, I grew up with a mother who was affected by polio. She was unable to use her left leg all the time that I knew her. And in the end of her life, that came back to affect her even worse with post-polio syndrome. So immunization is an important thing for me. Thanks.
Thank you for sharing. And last but not least, Bethany.
Hello, I'm Bethany Drapo. I'm from the Yankton Sioux tribe. I live in Wagner, South Dakota. It's been a few years since I moved back here. I was away, like going to college, and my link with Families Fighting Flu and the reason I'm on this panel is because I had a daughter who passed away from the flu in 2017. Now I'm a big advocate for vaccinations, and because like we never got vaccinated for the flu. It wasn't a big thing in my family, so losing my daughter Amaya really changed my outlook on vaccines, and now I'll take part in anything that I can to help advocate for that.
Thank you for sharing. So first, I'd like to start off the discussion by talking a little bit about some of the equality and access barriers that people of tribal descent face. Sonia, could you tell us a little bit more about some of the differences between tribal health, Indian health services, or private healthcare organizations?
Okay, sure, definitely. IHS, Indian Health Services, by tribal nation, those were established a majority by the treaties in which the tribes came together with the federal government to sign those treaties in regards to reservation living. And so, along with those treaties of healthcare and healthcare coverage, those are written into our treaties, and therefore the federal government has an obligation to then give to tribal nations and tribal people some type of healthcare coverage. A majority of tribal nations either has an IHS within their Chesney area, which is their tribal reservation boundaries, and or they've opted out for 638 facility, which is then the tribal sovereignty, and the tribe is able to govern themselves with the needs of their people and what they see is considered best access of care, best standards of care, and best practices.
Awesome, thank you. So does anybody have anything to add?
So for somebody that's accessing, so there's a big difference between like the three, like if somebody is going to Indian Health Services versus the 638 and then outside of that system. So for me personally, I grew up in Indian Health Services. The facility that I went to was an IHS facility in Tuba City. From I think it was established in like 1980, and then in 2010, 2012 is when they became a 638 facility. And so for that entire span of time, the biggest thing with Indian Health Services facilities is they run on a very limited budget, which means that they probably only have enough to pay like their staff and to pay for the few services that are really needed in the community. And unfortunately, what this means is there's a lack of access to a lot of different type of treatment modalities that most other people have regular access to. And it also means that if it's earlier in the year, that person will get the treatment they need. Later in the year, maybe there's not enough money, they can't get those access to those services. The other thing is also the way that providers, like the timing that you get with providers. So when it's Indian Health Services, you're going by federal. And so you get so many minutes with your provider, and it's very much like back to back, back to back. And then when the hospital that I went to became 638, you do get a lot more like in terms of because it's locally like decided what those services are. So for this facility that I grew up going to, when I was in high school, I needed an MRI. So I had to drive 2 hours to Flagstaff, and then that got charged like through my parents' insurance, and then the rest of it was covered by purchased and referred care. But then when I was in college, and now that same facility has become 638. And so now they have their own MRI machines. They have their own, a lot of those like just regular imaging services that people were getting referred to Flagstaff, which is 2 hours away, they could actually get locally. But the other thing is that, so there's a lot of positives to the 638, which is also that we can include things like traditional medicine. So the Tuba City facility has a traditional medicine department. But there are still limitations in terms of what those services look like and how much time. And that's one thing that I learned as a provider going into medical school, because then I learned about there's a lot of providers that get a lot more than 10 to 15 or 20 minutes with their patients. And that's something that if you don't grow up in Indian Health Services or going to 638 facilities, you kind of get to experience that where there's a lot more interaction and actually like choosing who your providers are and kind of building that connection with them. Because at the Indian Health and 638 facilities, unless it's somebody from your community that lives there, a lot of times the providers are also really transient. So you don't get to keep the same provider throughout your entire lifetime unless they become part of the community.
Interesting. Okay. And so when it comes to IHS versus these 638 facilities, how common would you say among different tribes and different reservations are 638 facilities versus how often are they more often or are they more often Indian Health Service facilities, like you said, which sound like they don't have as much funding and don't have as much access?
So for the Indian Health Services clinics, so I don't remember the exact number right now. So Indian Health Services was established in 1952. So from 1952 until I don't remember when the next act that happened, but I want to say it was around like the late 2000, like around 2010, around when Tube City became a facility, is when we had like the Self-Determination Act, that was really pushing toward the 638 creation. So that's a lot more like recent that the 638s have been around. A lot of facilities are going to be more of the Indian Health Services. Um, but we're increasing the amount of people and tribes and service areas that are starting to use the 638, which gives a lot more sovereignty and local control over how the healthcare is provided for the community. And then there's also some urban areas. So that's one of the things that Portland is looking at actually right now, is to be able to create like a 638 like pocket for the Portland area, because it's not super common for urban areas to have 638. It's more common for it to be like a compact through the local tribe.
Awesome, thank you.
Yeah, I'll just add that when we say 638, we use it as a noun and a verb and an adverb and an adjective, but it refers to the public law, and I forget, I think it's 92/638 or something, which gave set the framework for tribes to take over certain federal functions. So in addition to healthcare, they could also take over education and policing for their communities, things that had been provided by the federal government as part of the treaty agreements. Now the tribes could take it over for themselves. And what that means is that they get the funding that normally would have been spent by the federal government for that program. The thing that tribes can then do is add more money, if they have it, to make those programs more robust and make them, much more responsive to the community. And that's what we've seen with a lot of the tribes that have gone through that contracting and compacting process. Is they build these beautiful facilities that have all sorts of additional services provided that were not able to be done before because of the amount of funding that was available, which is determined by Congress every year. And most folks will cite that Indian Health Service is funded at about 50% of the need compared to the per capita expenditures of like Medicare or the VA, for example.
Wow. So it sounds like 638 is has a lot more benefits than an Indian Health Service reservation might have, or like a tribe that only has access to Indian Health Services. Can you guys talk a little bit more about some of the barriers that people face and some of the inequalities that they face when they're going to Indian Health Services versus when they're going to 638? Like, what are some of the challenges that patients run into? And inverse of that, what are some of the challenges that doctors might run into when they're treating patients?
Something that I don't understand about our IHS in my area is that, and it's probably funding issues, but instead of referring people out, the ones who depend strictly on, who have no insurance, they depend on the IHS, instead of referring them out or like a better way to like say my dad needed surgery on his back. He had like really bad, I think it was arthritis or something in his spine, and he needed surgery for it. Instead of them referring him out to get the surgery, the IHS would always just load him up with pain pills, and it would be tramadol was the main one that got everyone addicted on my reservation. So that's the main thing that they would go back and say, "Oh, this hurts. I need some more tramadols," and just causing addiction problems. So that was one thing that I've witnessed about the Indian Health Service.
So you mentioned Tribunal, and it's sort of a medicine, and I know it was mentioned before that some 638 facilities have traditional medicine centers also. What are some examples? We gave examples of some common medicines that people might be prescribed now. What other medicines are commonly prescribed that might be in place of other care? And what are some examples of the traditional medicine that was mentioned before?
I think in regards to traditional medicine, I think that's really a conversation of traditional healing practices that are traditional and specific for every tribal nation. I know there's various tribes that have, since they're 638, have adopted those traditional healing practices. And that is definitely something that has to go before legislation within the state. And then it kind of trickles down from there to Medicaid, and then Medicaid having those conversations with tribal nations to set those standards of how that's actually going to look and how it's going to be billable through Medicaid. And that's a really long process to get started. In North Dakota, they're currently having those discussions with the 5 tribal nations. And so really allowing either like a broad spectrum of traditional healing with the standards of Medicaid, or for every tribe to specifically uniquely tailor those services for their own tribal people. So really depending on the state and Department of Health with Medicaid and how that's going to move forward. Some examples of that would be like group therapy, like smudging ceremonies, talking ceremonies, sweat lodge ceremony. And to give a few, I know there's some tribal nations that have traditional birthing practices within their OBGYN ward. So it really is to the benefit of the tribal people of what they need and want, that to access the traditional care that they are deserving of, but then have it billable through Medicaid, and making sure that the traditional practitioners are involved and at the table as well.
So I guess when it comes to, obviously a lot of people of tribal descent are looking for these traditional medicines. When these aren't available, I know Bethany mentioned the Tradanol. What are some other like modern Western medicines that are commonly prescribed or commonly given out within Indian Health Services or 638s? Or is it just like, I guess, are there common medicines that are given out amongst all offices, or is it really just dependent on like the problem? Because Bethany had mentioned that that's sort of like a common prescription or a common thing that people are given on her area.
I can speak to that a little bit. So there is a common formulary of medications. So the Indian Health Service has a pharmacy and therapeutics committee that reviews medications on a regular basis. They develop a core formulary, which means that's a medicine that every Indian Health Service facility should carry. And then individual facilities can add to that, but they all have to have those medicines that are on the core formulary. And the core formulary is pretty inclusive of medications for, all the different conditions that we treat, from diabetes to heart disease to, other kinds of illnesses. The one reason why they have the core formulary, I think, is to make sure that there is sort of a standard of what is available, so that because some of these medications can be very expensive. When we were early in the days of treating hepatitis C, for example, that medication would cost over $10,000 or $20,000 for a treatment course. And that would break the budget of most pharmacies. And so it took a while before the cost of that medication came down, and through negotiated pricing and things like that, it was made more affordable and was actually added to the core formulary. And now the newer regimens for treating hepatitis C, which are more effective, those are being added to the formulary. So I would say that access to most of the needed medications is available, but the most expensive medications are going to be on a case-by-case basis as a way of trying to save some money.
Right. So then when somebody needs or is in need of these more expensive medicines and they don't have the proper access to get to it, what kind of alternatives would Indian Health Services or someone else usually provide, or what are some other examples of other alternatives that might be given to people?
So I think it's an example of what you were talking about, like the barriers to care is that if it's not in the formulary and the person doesn't have like third-party insurance and they're not on Medicare or Medicaid, then they don't get those treatments because then it's not available to them through Indian Health Services. And so like we've seen this even in my community, like around cancer, where like if the person as at an IHS facility, sometimes even like the access to treatment is just a lot longer because they have to go through purchase referred care to get referred to another facility that has those treatment options. And unfortunately, because they have to wait so long, they might have a worse prognosis than if they had been able to access that treatment earlier. And so that's just something that happens.
So there's a term that you just mentioned, purchase referred care. Could you explain that a little bit more too?
So there are certain services that are available within, we'll say if somebody's at like an Indian Health Service or a 638 facility, there are certain services that maybe they don't have that are not provided in that facility that they go to. And so there are certain services, and there's actually like a specific list of services that they could get referred outside of the facility that the facility will cover. And so that's what the purchase referred care is, that they get referred out, and then the facility will cover what they're charged outside of the facility for. But it's also like a very specific list of like things that they can get referred for. And there's always the possibility that like sometimes that money runs out.
So if somebody were to go to the doctor's office and that money had run out, then what would the next step be for either the patient or for the provider?
So they could get a medical bill, and unfortunately, that's what happens sometimes.
Yeah.
I think it also depends on the nature of the condition. So if it's a life or limb threatening condition, so if someone's in a car accident or motor vehicle crash, I should say, or is having a heart attack or is diagnosed with cancer, those are going to be at the top of the priority list. And even when it's the end of the year, there's a catastrophic fund as well that's available that's separate from the purchase and referred care. So there should always be funding available to pay for anything that's life or limb threatening. The gray area becomes things that might be considered more elective. So for example, bariatric surgery or a knee replacement or something like that. And in recent years, because of some other changes from the Affordable Care Act, actually, more and more people are qualifying for Medicaid in their states. And so in those facilities that have expanded Medicaid, the pressure on those funds for referred care is a lot less because the federal government is the payer of last resort. So everyone is expected to apply for Medicaid, and if they get Medicaid, Medicaid would pay for those referral bills, which means that we're not seeing the same level of depletion of those contract funds or referral funds at the end of the year as we used to, except in the states that didn't expand Medicaid. And so, which might be some of the states where you all are from. And that's a big issue. It creates this disparity for a program that's supposed to serve all Native people and yet it's not able to serve everyone equally. And that's a constraint of the legislation and I think an ignorance on the part of legislators in trying to meet those demands.
Yeah, absolutely. Just to go back, you keep mentioning the end of the year. Could you explain to people watching why somebody might not want to go to the doctor's office at the end of the year, or like what that has to do with getting treatment?
It's just that the fiscal year runs from October 1st to September 30th. And so each year, the referral care pot of money is renewed.
Gotcha. So just from my understanding, if somebody were to go right before, you know, if, at the beginning of September, they might not have as much access or treatment options as somebody who would go right after the year started because the money renewed.
That's possible, yes.
Okay. So my next question would be to wrap up the equality and access. What are some of the differences between different tribal nations and different tribal areas when it comes to access and barriers? Are there different barriers that different tribes face, or do we think more by region, or is it just a matter of access of the medicine in IHS versus 638?
In my area, the only difference that I've seen is dental work. There's a lot of times where we don't have a dentist, so we travel to the next IHS facility and use their dentist.
I think dental care is really, and I actually wrote it on my notes here, for a lot of tribal nations, that's the biggest issue. Because, you think of dental care and the saliva we have in our mouth is really close to our heart. And so it really, when it impacts cardiac arrest or any cardiac issues that, we might be experiencing, whether as older people or younger people. And I think the other barrier to having dentists and dental hygienists is for them to come and live in our tribal communities. That's, I think, the hardest barrier, is to get them to live within our reservation boundaries and then to live within our communities. And so, when we could come up with a big list of transportation, we can come up with medical insurance and first primary payer, which, is in our tribe, we really push for our tribal members to get enrolled in Medicaid. And so, and then there's a lot of, discussion and people saying, well, as Indigenous people, we're deserving of our treaty rights, which is free healthcare coverage. But then if your facility is 638, then your tribe is directly paying for your service and your care. So it's better to be under Medicaid, and that coverage will then come out of the pot of money from North Dakota State versus the tribal nation. And so I think a lot of people don't understand that. It's really an idea of changing people's thought processes around IHS versus 638, and what are the benefits and what are the differences. And when it comes to North Dakota, we have 2 tribes that are 638 and 3 tribes that are IHS. And so even on a state level, in regards to or a local level or a tribal level, people understanding the differences and how the money is spent and how the money is then, for IHS services or tribal nations, we have to have those encounter rates. And those encounter rates are the rates that if you're 638, they go before tribal council, you get your monthly report and they're like, okay, we've had these many encounter rates, we've had these many patients. But then if it's local health, say doing a vaccination event, who gets those encounter rates? Is it local public health or is it IHS and 638? Those encounter rates, unfortunately, for the one individual, there's a dollar sign behind them. And so really having that understanding of, we do want people to come to our reservations to help us in our tribal nations, but they need to understand what is currently occurring within tribal nations historically with policies and procedures around public health and tribal health, so that they can better understand how to best help. Because when people start to, not see clearly eye to eye with those encounter rates, it definitely hinders the care of the people. And so how do we best give best care to our people is to then understand how do the state, local public health, and even other tribes work with one tribal nation. There's the relationship building, the trust, the communication, and that is built over time. It's built over years and interactions and face-to-face conversations. And so that's another barrier, which I feel if our people don't understand that, whether tribal or non-tribal, it definitely impacts an individual's health, but then it impacts the whole tribal nation's health on next steps and how to move forward.
Yeah, thank you. That was very informative. So you had mentioned something else that I hadn't really considered. When you talked about getting doctors and other healthcare providers to come live on the reservation, that seems like it would be difficult to convince people to move or to like live in areas that they're unfamiliar with. When like a health care provider comes to work at one of these 638s or these IHSs, how ingrained with the community are they normally, or are they coming from outside? Like, do they normally drive into these places, or what's normally the practice and procedure with that?
I feel that is really like when an individual comes for an in-person interview, that is all explained at the forefront, I would hope. And I know at our tribal facility, that is, we talk about our tribal history. We talk about our generational traumas have occurred within our tribal lands and with our tribal people. But also, providers are going to be coming, either they're going to move to an urban area and drive the distance, whether 1 hour or 2.5 hours back and forth to and from work, or the facility will provide housing. And sometimes providers will share housing. Sometimes we'll get locums, which are then locum nurses or locums for, say, the pharmacy or the lab or imaging. So it really depends on what the contract is, and it depends on what amenities are in your community, and a lot of people think of education, they think of housing, they think of schooling for their children and grocery store access and the safety of their family. So yeah, it's a big ask to have somebody, a medical provider and a specialty provider, move to your community. And if the provider is welcomed by the community and is very ingrained in the community will adopt them, and they'll start to come to community events. And it's really nice to see that when that happens, from my experience.
Yeah, that does seem like the ideal route. Before we go to the mistrust in messaging, is there anything that anybody wants to reiterate, or anything that you guys think that we missed that we should touch upon when it comes to barriers to access and the inequalities that tribal people face?
I have a couple of things that I think might be relevant. One is, you sort of touched upon it with this last piece of discussion, which is the rural nature of most reservations. I mean, in Indian health, we face a lot of the same problems that rural communities are facing, just in getting people to come to those communities. And it's a struggle all over the country for rural healthcare. And there are programs to help attract providers and make it more possible for them to do that. But it is a huge barrier, and I don't think that there's any magic wands to try and do that. Not every tribe has housing available for their healthcare providers. Places that I've been, where I first started working with Indian Health Service in Whiteriver, Arizona, there was housing provided for providers, and And that made a huge difference. So we lived on the reservation for 7 years. Our kids went to local schools. My babies went to local daycare. And it was really a great experience. It was difficult to leave. But it's not every place has that ability, I think. The other point I wanted to make is, and maybe we'll get to it later on too, is there's a program called the Vaccines for Children program. So CDC funds the Vaccine for Children's program through the states, and American Indian and Alaska Native children are automatically qualified to receive their vaccines paid for through the VFC program. So whether they're going to an IHS or a 638 or a private or public facility anywhere in the state, they're eligible for those vaccines, and there should be no cost to families for their vaccination services. And so that's one way that, hopefully access and equality are being provided for.
I have two other points. Students that leave for college or vocational schools from the reservation, they're used to going to IHS facility or their local 638, but then when they go into the urban settings, they're really lost when it comes to navigating the larger facilities. And so I think it's a little bit cumbersome for them to try to understand that at 18, 19. And so I think I see a lot of college students that struggle with accessing healthcare in the urban or in the rural areas. Urban areas. And so I think that is really a large barrier. And then the other barrier is within IHS or 638, when an expecting mother is then sent out to a larger facility for delivery. Case management is a big concern, and the follow through with continuation of care and medication for the individual. And so that's another big barrier that we face. And it's not only expecting mothers and their child, but it's also, say, people that have gone on to PRC, got their patient referred care, they've gone out for surgery or some treatment. Their home facility, IHS or 688, is unaware that they have been released from the hospital. And that goes again to individuals who have been incarcerated and have gone into the medical care system and or state facility. There's no case management for them either. So I feel like case management, that's a big barrier and a big hole in the gap with IHS and 638 is having that continuation of care when they do come home.
Yeah, that's a very good point. And so you talk about how sometimes like a healthcare facility won't know that they've left, or that they don't know that they're not taking other medicines or stuff like that. Is that a common thing for medical records not to transfer over from one office to another or one facility to another?
So ideally, when a patient comes to a larger facility, they are given their PRC, patient referred notice. So the facility is aware that they are to get care, and then they have X many of follow-up appointments. Say, I think it's anywhere between 4 to 6 follow-up appointments and additional treatment if they need so be for that patient. But it is the responsibility of the facility that has seen them, and if they've occurred, if the surgery has occurred, then that facility is responsible then to communicate, but that seems to fall off the radar of the larger facility and the urban area. And I've been told that even at the ER, when a patient goes to the ER or further patient referred care, at that point when the patient is a patient within the facility, the discharge papers, as much as the patient's new chart starts, but then the discharge papers should be starting too as well, to then notify and it being in the patient's chart saying the patient is coming from this area, and follow through has to be happening upon discharge whether the continuation of care, the continuation of medication, there's a breakdown in that process. And I see nods because I think everyone agrees and sees that as another barrier.
So when there are some, illnesses or ailments that are a little bit more under the radar that aren't as obvious, at first, are there any barriers to these facilities, these IHS services, or any of these? Like, what kind of problems are they running into when they're trying to test or survey for these problems or these ailments?
And I think if it comes down to referring someone to a specialist, like if there's a joint problem and one's not sure and you think maybe they should see a rheumatologist or orthopedist, then you would want to refer them out. Most of the times, particularly for ortho, they'll want imaging beforehand. So they'll say, well, once you get the MRI, then we'll see the patient. And then even further downstream, some conditions will say, well, you actually have to do physical therapy and not get better before you get the MRI, before you can see the specialist. And so that sort of is how sometimes care can seem like it's getting delayed. I don't know that it's that different on the outside of the system either. For back pain, usually it's physical therapy, then MRI, then ortho referral, if things aren't improving. But different places might have different protocols that they use. So.
Wow, I cannot thank all of you enough for this very insightful and robust conversation. I realize that each tribal nation is unique and independent, and it's really difficult to try to talk about healthcare and access broadly when there are so many unique situations and unique communities. But you guys have done an amazing job being really, really helpful in sharing and understanding about the barriers and the nuances of seeking healthcare in Indigenous communities. So thank you so much for that. And when we think about access to immunizations and that importance of ensuring that vaccines are happening and increasing vaccination rates in Indian country, having this understanding about access to healthcare in tribal communities is essential. And I just can't thank you enough. And again, I'm Ruth Hirschman with the Excite Project at the Extension Foundation.